Hello guys, I hope all of you are doing well. I'm Dr. Ranjan, your pharmacology faculty. And guys, we are already into the second week, as you can see, autonomic nervous system. And the first week was amazing, guys, the way you have participated in the last video of the general pharmac that I premiered. And though we could not do it live, but I was amazed by the way you guys participated and answered. And it was amazing, guys. It was amazing. And the very reason of why I'm doing these sessions is so that I can contribute to your preparation other than whatever I do in my online or offline lectures, right? And I've got your reviews, I've got your comments, and I was really happy that this is helping you. And believe me, guys, if you continue doing this until the last week, which I have planned, at the end of the day, all of you who are following this will come out as winner, and you would have aced a subject like pharma, right? So as I said in my first session as well, autonomic nervous system, again, today I'll discuss 15 new questions where you have to participate, you have to comment the answers, commit yourself to the answers. These are again 15 questions which are new ones. They are not PYQs, you'll not find them anywhere. I have made them again specifically for you so that you can learn something new and so that you can solve some new type of questions which can be asked in your exams. Wherever possible, I've tried to include MCQs which are more clinical because all of you know nowadays the MCQs are more clinical oriented towards how you're going to treat a patient, right? So again, guys, I always try to do it a live session, but when I cannot do, I premiere the video. So even this time I would not be able to come live because again, I have another commitment of an offline FMG class in Gautam Nagar in Delhi. So after the class, it would become difficult because I would be low on energy, and I don't want to be low on energy when I'm doing this. So rather, I would go for a recorded video which would be premiered. I would be in the chat box, and in this video, I would be in this whole process with you guys. I'll be cheering you guys up. I'll be answering your queries as well, right? So, guys, let us dive into today's session, autonomic nervous system, right? So, guys, as you can see, autonomic nervous system, the first question that we're going to discuss is a clinically oriented question. Respiratory paralysis can be seen with all except. So, respiratory paralysis is one of the clinical presentations that can be seen with all except. Look at these options, guys. Option A, myasthenic crisis. Option B, botulism. Option C, gentamicin toxicity. Option D, scorpion bite. Now, this MCQ, even if you don't know anything, you can make a guess, right? So as I always say, pause the video. You can take few seconds, 20 seconds, 30 seconds, as much as you want. Think the question thoroughly, then go for the answer. Even if you don't know the answer, I think there is a possibility that you'll land on the right answer. Many times happens, right? We don't know. So, or you can rule out one or two options, then get the answer. Now, it is an important topic, and you'll see here I'll connect a lot of drugs to this one clinical presentation that is called as respiratory paralysis. How will I do that? Let us go to our next slide. See, acetylcholine is a neurotransmitter, as you can see in this diagram, and whenever this presynaptic neuron is depolarized, so action potential will depolarize. Whenever it is depolarized, what happens is there is opening of presynaptic calcium channels. So voltage gated calcium channels will open. Calcium moves in, which is responsible for contraction of this vesicle, and the vesicle begins to move forward, and that is when acetylcholine is released. Acetylcholine is released into the synapse. Now, this acetylcholine binds to NM receptor, and this will be responsible for skeletal muscle contraction, including my respiratory muscles. For respiration, I need this process very much. So I'm converging gradually into respiratory paralysis, right? What are the drugs or toxins that can hinder this process of acetylcholine release or binding to NM receptor? Let us see. What I can do is I can block these presynaptic calcium channels by class of antibiotic called as aminoglycosides like gentamicin, streptomycin, amikacin, etc. So if I block these calcium channels, calcium won't move in, acetylcholine would not be released. So aminoglycosides will decrease release of acetylcholine. That is one point. Number two, I can directly block release of acetylcholine by toxins like beta bungarotoxin and botulinum toxin. So beta bungarotoxin can be, it is also present in some snakes, and botulinum toxin, it is due to botulism. They'll also decrease release of acetylcholine, but the mechanism of decrease in release of acetylcholine is quite different, right? Second, what happens in a disease? Now I talked about acetylcholine release by different mechanisms. Indirectly, I can decrease acetylcholine release by giving aminoglycosides. Directly, I can decrease release by toxins by like beta bungarotoxin or botulinum toxin. Then let me talk about a disease. Let us talk about a disease called as myasthenia gravis, where there is myasthenic crisis specifically. In myasthenic crisis, there are antibodies, and myasthenic crisis would be seen when there is too much of antibodies, and these antibodies, they block NM receptors. So myasthenic crisis would be because of block of NM receptor. Can anything else block NM receptor? Let's talk about a snake, cobra. So cobra toxin, it also blocks NM receptor. Cobra toxin also blocks NM receptor. Now, I have described a bunch of conditions which can either decrease acetylcholine or block NM receptor, because of which, if I look at the end result, see, whenever you decrease acetylcholine or you block NM receptor, the end result would be same. The end result would be a decreased skeletal muscle contraction. So this can result in respiratory paralysis. So what could result in respiratory paralysis if there is aminoglycoside toxicity? A snake bites snake which has beta bungarotoxin like crate. Botulinum toxin. Botulism can also cause respiratory paralysis. In myasthenia gravis also we can have respiratory paralysis. Cobra bite also we can have respiratory paralysis. So in none of these, whenever there is a respiratory paralysis, one thing that I can use for treatment is mechanical ventilation. Is an important mode of treatment in all of these conditions whenever there is respiratory paralysis. So I told you I'll converge into skeletal muscle contraction by describing multiple aspects, disease or toxins or drugs, right? Now let us go back to this MCQ. Now, if someone has not answered, now guys, can you comment the answer now? What would be the answer? Obviously, what is the answer here now? See, myasthenic crisis, yes, it can cause respiratory paralysis. Botulism can cause. Gentamicin toxicity also can cause. What is it? Sorry, scorpion bite. So scorpion bite can cause hypertension, pulmonary edema. I have another MCQ included on scorpion bite. I'll discuss at last that MCQ. So your answer is scorpion bite here, guys. So I have told you time and again, in these sessions, I'll be asking new MCQs, right? They would be from moderate to difficulty levels. There is no point in asking easy MCQs. You'll find them everywhere. So the aim here is to find out if you guys in the last 1 week have adequately understood autonomic nervous system or not. So if there is some gap in your understanding, we'll try to fill up that gap in these sessions. That is the main aim of these sessions, right? Let us move on to the second question, guys. Which of the following match is correct about sweating and its block? Look at the options. Sympathetic nervous system and sympatholytic. So it is about sweating caused by which system? Sympathetic, and block caused by which system? Sympatholytic. That is how this question is. Option B, sympathetic parasympatholytic. Option C, parasympathetic sympatholytic. Option D, parasympathetic and parasympatholytic. So which nervous system, sympathetic or parasympathetic, causes sweating, and which class of drug blocks it? This is the option. You can take your time. We are not rushing anywhere, right? There is no timer here. Take all the time you have. You can pause the video and you can then answer. Take your time, process the information. Say this MCQ has been asked in different ways. I'll tell you how it has been asked, right? And you basically try to answer now whatever you think is the best answer. So guys, you have to comment. You have to commit to an answer. Even if you go wrong, There is nobody, no one here to judge you, right? At least not me. So let me tell you a little bit about sweating, which system causes it, which system can block it. So all of you would agree with me. Suppose this is a neuron. So let me have some water. So guys, suppose this is the sweat gland and this is sympathetic nervous system. So all of you know, when do we sweat? Whenever there is sympathetic nervous system, whenever it fires, right? That is what is causes sweating, isn't it? So sympathetic nervous system neuron, this is one of the axons, it supplies the sweat gland, right? But if you know, I've discussed this in my lectures, the neurotransmitter in the sympathetic nervous system is acetylcholine. So whenever acetylcholine is released, we understand it is not going to act upon alpha or beta receptors of the sympathetic nervous system. Rather, it is going to act upon a receptor of parasympathetic nervous system, because the neurotransmitter is acetylcholine. Now, what would be the receptor here, guys? Which receptor? M1, M2, M3. Yes, the receptor would be M3 receptor. So, what is the cause of sweating? The cause of sweating is, if I start from the beginning, it is firing of sympathetic nervous system, but not release of norepinephrine, rather release of acetylcholine binding to M3 receptor, and this is what is responsible for sweating. So one point I have got it right. Sympathetic nervous system is what is responsible for sweating. But as you can see here, sympatholytics, they cannot block sweating. To block sweating, I have to block M3 receptors. An M3 receptor blocker like atropine or a toxin like datura toxin can block sweating. So atropine toxicity or datura poisoning can block sweating. And if I block sweating, what's going to happen if I block sweating? What is going to increase? My temperature is going to increase. How would be the skin? The skin would be dry. So dry skin and hyperthermia would be a presentation of atropine poisoning or toxicity, or datura poisoning, or even belladonna poisoning can cause these symptoms, right? So in other words, what do I learn here from this? Now, if you have not yet answered, can you answer the MCQ now? Now it is a cakewalk, isn't it? So what is the answer here? Sympathetic causes it. So my answer would be A or B, but it is not sympathetic sympatholytic, rather it is sympathetic parasympatholytic. Now, it might seem confusing looking at all sympathetic, sympatholytic, etc. But the answer is not difficult if you understand the basic concept, right? Now, moving on to the next question, guys. A 55-year-old male presented with flashes and floaters in both eyes. He was started with pilocarpine for treatment of presbyopia before 5 days. Which of the following condition the patient has developed? See, for presbyopia, usually patients of 45 to 55 years of age, they can be prescribed pilocarpine, right? And which causes, accommodation muscle or ciliary muscle contraction. Now, he developed flashes and floaters in both eyes after 5 days of giving pilocarpine. What could be the reason? Option A, vitreous detachment. Option B, vitreous hemorrhage. Option C, uveitis. Option D, retinal detachment. So it is a clinical MCQ that I have asked. Again, this is a new MCQ. An MCQ similar to this has been asked, but I made the question more clinical because this is how the patient will present to you, isn't it? So guys, what do you think is the answer? Pause the video, comment the answer, commit to an answer in the comment box. You must comment, guys. You must comment. You must commit to an answer, right? So let us see. Now, first of all, flashes and floaters, they can be seen with all these conditions. What I need to know is, what could pilocarpine be responsible for among all these options, right? Now, see, pilocarpine, what are the side effects? How have I taught you pilocarpine in my classes? Pilo, the initial two words are pilo. Pilo in Hindi means drink, isn't it? Now, for those who don't understand Hindi, I'm translating for them. So, pilo means drink. And to drink, you have to go to a bar. You have to go to a bar. So, bro ache is headache during the lines of bro. A for accommodation spasm, and R for retinal detachment. R for retinal detachment. Now see, these are the three side effects I teach you in my classes. And obviously, this is an MCQ related to pilocarpine. So you have to just recall these side effects and try to understand what could be the reason and what could be the answer here. It's not a difficult, it's not a difficult MCQ at all if you remember the side effects, right? So I've told you time and again, the very purpose of this exercise for us is to increase our retention week after week after week after week, dividing pharma into as many parts as possible. Gradually, slowly, steadily, we'll begin to conquer pharma, guys. And you'll see you'll come out as the real winners after this exercise. So retinal detachment is the answer. It's not a difficult MCQ if I understood the concept, right? Next MCQ. Neostigmine is used to target all of the following organs except bladder, GIT, brain, muscles. I told you most MCQs I'll give you moderate to severe ones, but this is one easy MCQ. So see, I'm also human. I'm also a kind person, right? I'm a kind person, so I won't give all the MCQs difficult or moderate ones. This is one easy MCQ that I've given you so that you can answer, feel happy about it, and I can teach you something, right? So what is the answer, guys? I don't think you need to pause the video. You can straightly shoot the right answer in this MCQ: bladder, GIT, brain, muscle. Now all of you know neostigmine is a drug that does not cross blood-brain barrier, and obviously your answer would be brain, isn't it? So what is that I want to teach you guys, right? So those who have attended my lectures, they would know what I'm about to say. Now those who have not attended my lectures, for them I'm gonna teach something. See, whenever I do not cross blood-brain barrier in autonomic nervous system, my target organs are three, like bladder, GIT, and muscle. Bladder, BGM. So this is just a short form to remember. Bladder, GIT, and muscle, right? So whenever I target bladder, my uses are like bladder atony. My uses are like post-operative urine retention. GIT. My uses are like gastroparesis, paralytic ileus. Muscle. What are the muscle uses? Myasthenia gravis, NDMR reversal, and cobra bite. Right now, for which drugs that do not cross blood-brain barrier and are used for B and G. So there is one drug called as betanicol that do not cross blood-brain barrier and it is used for B and G. It means these four uses. Whereas, let us talk about another drug that also does not cross blood-brain barrier and it is used for all of these. It is used for B, G, and M, and this drug is called as neostigmine. Right. So neostigmine, betanicol, they're quite similar drugs, and their uses are quite similar, except that neostigmine is a drug that can also be used for M or muscle, where I target NM receptor, That is the reason why whenever I'm going to use neostigmine, then in these disorder, I'll also add atropine. So if I use neostigmine in myasthenia gravis for a diagnosis, then I can use atropine. NDMR reversal, I can use atropine. Cobra bite, I'll use neostigmine plus atropine. So this is what I want to teach those students who have not attended my lecture, so that you can understand how two drugs are related to each other. Betanicol, and betanicol, why it is not used in M? Because betanicol does not bind to NM receptors. It has no NM action. It has no nicotinic action, so to say. So it is only muscarinic action. So it is only used in bladder and GIT. All right, guys. Moving on to the next question. Which of the following drug and site of action on ACHE is incorrect? Now see, the net board, they have started asking MCQs on site of ACHE and drugs acting on them. Right? The most recent MCQ was in an FMG exam, but you know, nowadays the FMG exam questions and the NEETPG, they are quite similar, even they are cross repeated, right? Now, Look at the options. Option A, organophosphates, asteretic site. Option B, carbamates, asteretic and anionic site. Option C, pralidoxin, asteretic site. Option D, adrophonium, asteretic site. Right. So what is the answer, guys? Pause the video. You can think for a while. Let me know the answer in the comment box. I've taught you this. I've taught you this. Since they have started asking MCQs, I've made an MCQ. Again, it's a new MCQ, right? What do you think is the answer? So I hope you guys have commented. Now, let me tell you, let us move on to the next slide. Now, all of you know, this is how I've told you ACHE looks like. The structure of ACHE, this is how it looks like. It has two sides. There is an acidic site, there is an anionic site. Anionic site, it is a negatively charged. So it serves as a site of attachment. Acidic site, it breaks down ester bonds, right? Now, let me quickly tell you about drugs that bind to different sites. So let us talk about organophosphates. So yes, organophosphates, they bind with a phosphate bond only to the asteretic site, right? Whereas pralidoxin is an oxime. It has positive charge, so it binds only to the anionic site. So organophosphates, they bind only to asteretic site. Pralidoxin binds only to anionic site. And by binding here, what it does, it breaks the phosphate bond and removes organophosphate from this side. That is the reason why pralidoxin is also known as ACHE reactivator, right? Now, coming to carbamates, see, carbamates, they block both acidic and anionic site. But there is one non-carbamate called as adrophonium. Adrophonium, it blocks only anionic site, and because it has a positive charge, it blocks only anionic site. Now, this is where these drugs act, and they can ask you MCQs where they act. This is the reason why, what can I conclude? Whenever I have an organophosphate poisoning, I can use pralidoxin. But if I have a carbamate poisoning, I cannot use pralidoxin. The reason being, the anionic site is blocked. Pralidoxin cannot bind. If I have, suppose, adrophonium toxicity, even in that case, I cannot use pralidoxin because anionic site is bound. So there is one concept I can understand from the second point is adrophonium, because it has positive charge and it binds to a negative charge, the bond is ionic, and because of which it attaches, immediately detaches. So among all the drugs in this carbamates or non-carbamates, it is the shortest acting drug. And you know, shortest acting drugs are usually not preferred for treatment, they're rather preferred for diagnosis. So this is something I have taught you. Adrophonium is the drug of choice for diagnosis and differential diagnosis of myasthenia gravis and cholinergic crisis. So this is the conceptual part that I had to teach you guys. Now coming back to the MCQ, which of the following drug and site of action on ACH is incorrect? Even if you have not commented up until now, can you just try now to find the right answer? So what could be the right answer? Look at this. Say organophosphates, acidic site, yes. Carbamates, both acidic and anionic site, yes. Pralidoxin, acidic site, yes. Adrophonium, acidic site is not correct. So this is my answer. Adrophonium binds to which site? Anionic site, right? Now, moving on to the next question, guys. What is the dose of atropine used for treatment of bradycardia? 1 milligram IV, 1 milligram subcutaneous, 0.5 milligrams IV, 0.5 milligrams subcutaneous. What do you think is the answer, guys, here? What do you think is the answer? Pause the video or don't pause the video, comment immediately. Now, you know, many of you will go for the answer as 0.5 milligrams IV, but remember, it is wrong. It has been updated. For bradycardia, now the answer would be 1 milligram IV. So 1 milligram IV, I can give one dose. If the patient does not respond, I will repeat. I'll repeat another 1 milligram after 3 to 5 minutes, right? So again, so I can maximum give 3 milligrams. So I can repeat 1 milligram IV, first, second, third dose. 3 doses can be repeated at interval of 3 to 5 minutes, depending upon how the patient's heart rate is responding. Now the dose has been updated to 1 milligram IV should be given. That is one thing. Second thing is atropine at doses more than equal to 0.5 milligrams increases heart rate. And that is the reason why precisely I'm using a dose of 1 milligram IV, which is more than 0.5 milligrams for treatment of bradycardia. But you have to learn another point here, and that is atropine at doses less than 0.5 milligrams, it itself decreases heart rate, or this is called as paradoxical bradycardia. Paradoxical bradycardia. And this paradoxical bradycardia is something they can ask you. Second thing, they can ask you why. Why does it happen? It is because of block of presynaptic M1 receptor. So I'll not go into the details. I've taught that in the lectures. So they can ask you, number one, at what doses atropine causes bradycardia less than 0.5, or they can ask you at less than 0.5, what would be the effect on heart rate? Second, they can ask you paradoxical bradycardia is seen with atropine. The reason is M1 receptor. So I told you earlier, in these lectures, you might find something new. Specifically, if you have not attended my lecture, what you need to do with those new points, just go to your notes, add them to your notes, right? All right, guys, moving on to the next point. Which of the following drugs should be used to begin treatment of urge incontinence? Mirabegron, trospium, darifenacin, oxybutynin. All right. What could be the answer? Pause the video, think it thoroughly. Let me know the answer here. Right. I hope you guys have commented the answer. Now let me explain. I know many of you would comment darifenacin is as the answer here, but it would be wrong in today's world. The drug of choice for urge incontinence, it has been updated, and currently it is mirabegron. So urge incontinence or overactive bladder, urge incontinence or overactive bladder, the current drug of choice is mirabegron. The current drug of choice is mirabegron. So mirabegron is first line, it is drug of choice, right? The second line drugs are anticholinergics. Second drug of choice are anticholinergics, and two drugs which are preferred to begin the treatment is either trospium and darifenacin or solifenacin. So why these two drugs are preferred in anticholinergics to begin treatment? The reason is because trospium does not cross blood-brain barrier. That would have one benefit. I'll tell you what is that benefit. Darifenacin, it is M3 selective. M3 selective, right? So now what happens is, whenever I use anticholinergics, there is a high risk of dementia. There is a high risk of dementia. That is the reason why we have moved on to mirabegron, which is a beta-3 agonist. Beta-3 agonist for treatment of urge incontinence. For treatment of urge incontinence, because there is a high risk of dementia with anticholinergics, right? Now, you would ask, sir, trospium does not cross blood-brain barrier, right? It would not increase the risk of dementia. Yes. See, whenever I say a drug does not cross blood-brain barrier, it actually means it crosses blood-brain barrier but lesser, right? Darifenacin is M3 selective. So you would ask, sir, how would it cause dementia? Because dementia is due to M1 receptor block. See, whenever I see a drug is M3 selective, it means it blocks M3 more than M1. So even trospium or darifenacin can cause some degree of dementia, but it would not be as great as other anticholinergics. That is the reason why I precisely say, if I use an anticholinergic, I'd go for either trospium or darifenacin. So this is the recent update on treatment of urge incontinence. So what is the update? Number one, I should be using beta-3 agonist, that is mirabegron, right? My first go-to drug. Second, if I cannot use mirabegron, for example, where I cannot use mirabegron, let me give you the most important example. Mirabegron beta-3 agonist, it is contraindicated if a patient has uncontrolled hypertension. So if there is a patient with uncontrolled hypertension, in that case, I cannot use mirabegron. So I'll go for anticholinergics. So guys, your answer is mirabegron here. So this is something which has changed. So people who have even attended my lectures, please change this in your notes. Please change this in your notes, right? Now coming to a graph, graph-based MCQs, they are asked quite frequently in autonomic nervous system. Look at this MCQ again. It's a new MCQ that I made. Which of the following graph of heart rate belongs to norepinephrine in a patient with transplanted heart? So norepinephrine transplanted heart. There are four graphs of heart rate, A, B, C, D. Options A, B, C, D. Take your time, pause the video, ponder upon the question, try to find out what could be the right answer here. Now let me know the answer in the comment box, guys. You must commit to an answer. You must comment the answer, right? I hope you guys have already commented. Let us come back to it. Come back here. Now see, some of you might comment the answer as C or D, but remember that would be the wrong answer. Why? Let us try to understand. See, there are catecholamines. There are catecholamines which increase contraction of heart. Right? All of them, they will increase contraction of heart, but they would have variable effect on heart rate. Either it can increase significantly, it can increase but not that much. Either the heart rate can be normal, right? So either it can increase too much, it can increase but not that much. Either it can be normal or heart rate can decrease. This is something I have taught you guys, right? Which is this first drug. It is isoprenaline. This one is epinephrine. This one is norepinephrine, right? Can you tell me which drug this one is? Let me know in the comment box. Come on. Comment faster. Which one is this drug? Which one is, you know it. Which one is this drug that maintains a normal heart rate but increases contraction of the heart? Come on, guys. Come on. Comment. Let me know. Which drug is this? This drug is dobutamine. This drug is dobutamine, right? So, this is what I know. Isoprenaline causes significant reflex tachycardia. Epinephrine also causes tachycardia, but it is not as significant as isoprenaline. Dobutamine maintains a normal heart rate. Norepinephrine causes bradycardia, and this bradycardia is because of vagus. So what if this vagus is blocked? For example, the patient is on atropine, or what if the vagus is cut? For example, the patient is on a transplanted heart. Now, in this case, vagus is gone, and that is why norepinephrine would increase heart rate. Let us go back to the MCQ. Now, at least now let me know what is the possible answer here, A, B, C, or D. What is the answer, guys? Obviously, the answer is which one? Answer is option A, because this is the only option which shows an increase in heart rate. Now see what I have done. I've taken the same MCQ which has been asked multiple times in our exams. I've just turned and twisted and made a new question, right? It's pretty much logical. They can ask you such MCQ. Now, all these drugs, they can increase contraction and bring about some change in the heart rate. Now, let me ask you another question. Can you tell me which drug which maintains a normal contraction of heart? Which drug maintains a normal contraction of heart and decreases heart rate? See, norepinephrine increases contraction, right, and decreases heart rate. I'm asking you, is there any drug that maintains a normal contraction of heart but decreases heart rate? It is a drug from cardiovascular system. We discussed about that drug. Come on, answer. If you cannot answer, I'll give you a second clue. It's a drug that is primarily used in angina. Now you should be able to answer. Okay, I'll give you a second clue. I'll give you a third clue. It starts with alphabet I. I for, guys, come on. Now you can answer. I for ivermectin. So guys, in this one slide, I've discussed all the drugs which have action on heart contraction and heart rate, so that you can process this information at one place. Moving on to the next question, guys. Epinephrine is preferred over norepinephrine in anaphylactic shock due to affinity for which receptor? Alpha 1, beta 1, beta 2, alpha 2. It is not a difficult MCQ. I can say it's not an easy one either. It is a moderate MCQ. But if you would have understood the basic concept of how epinephrine is different from norepinephrine, it would be a cakewalk, right? So again, if you want to take some time, pause the video, let me know the answer in the comment box. Comment, guys, comment. You have to comment. You have to commit to an answer. You might go wrong. Nothing, to worry about it. So if you know that epinephrine is a drug, it acts upon alpha 1, beta 1, and beta 2. Norepinephrine alpha 1 and beta 1. So what's missing from norepinephrine is beta 2. And that is the reason why in anaphylactic shock, I use epinephrine but I do not use norepinephrine because anaphylaxis is due to histamine. So if you look at this case, anaphylaxis, it is due to histamine, and histamine will produce vasodilatation and bronchoconstriction. So I want a drug that can tackle vasodilatation by vasoconstriction, which epinephrine, norepinephrine both can do. But I also want a drug that can tackle bronchoconstriction by producing bronchodilation, which is not possible with norepinephrine, but it is possible with epinephrine because it is also a beta-2 receptor agonist. That is the reason why your answer here is which one? Which one? Beta-2 receptor. So remember, for all types of shock, I prefer norepinephrine. Because whenever I deal with shock, my main aim is vasoconstriction. Norepinephrine is a much more potent vasoconstrictor as compared to epinephrine. So when I want vasoconstriction in a disorder like shock, I go for norepinephrine. Except anaphylactic shock, where I not only want vasoconstriction, but also want bronchodilation, I prefer epinephrine because of beta-2 receptor, right? Next question, guys, let's move on. It's a clinical case that I made specifically for you guys. A 25-year-old male presented to the emergency with low blood pressure and bradycardia after road traffic accident. Which of the following drugs should be immediately started for stabilization of the patient? Epinephrine, dobutamine, norepinephrine, vasopressin. What do you think? What do you think is the answer? Now, I know it's a clinical question. You need some time to process the information. I'll give you the time. Take your time, pause the video, ponder upon the question, come with the right answer. Now see, many of you guys here might think that epinephrine is the answer because there is bradycardia, but it is not the right answer. Let us try to process the information, what has happened. So whenever they'll give you a young male, right, had an RTA, mostly because of driving a bike. This is usually what happens. You're driving a bike, you skid, you had an accident, and you present to the emergency with low blood pressure and bradycardia. Now remember, this cannot be hemorrhagic shock. The reason being, if there is low blood pressure, you might be going into shock. If there is hemorrhage, there would be low blood pressure, but there would be tachycardia and not bradycardia. So whenever there is low blood pressure and bradycardia, it tells us it is not due to loss of blood. It tells us something else. It tells us damage to some part of your body that supplies your cardiovascular system, that supplies not only heart, so there is a block on the heart, but also blood vessels. That is the reason why you see this. Now this happens in case of neurogenic shock. This is what happens in neurogenic shock. So what happens in neurogenic shock? In neurogenic shock, it is usually due to spinal cord trauma. So spinal cord fracture can be there, and there could be damage to the spinal cord in the thoracolumbar segment, which supplies the cardiovascular system. And that is where you have low blood pressure and bradycardia. Now it is seen as in neurogenic shock, right? And what is the drug of choice for neurogenic shocks? I've told you earlier, most shock, the drug of choice is norepinephrine, except anaphylaxis. So neurogenic shock, septic shock, they'll give you a case of sepsis, burn patient, cardiogenic shock. 3 shocks where norepinephrine is drug of choice. So here, your answer is norepinephrine. Now since I'm teaching you this, let me give you another condition where you can have low blood pressure and bradycardia. One condition is this. Second condition where you can have low blood pressure and bradycardia, it is with spinal anesthesia induced hypotension. Now, if there is spinal anesthesia induced hypotension, it can also cause bradycardia, right? So now remember, spinal anesthesia induced hypotension, my drug of choice is phenylephrine. My drug of choice is phenylephrine, but phenylephrine itself causes bradycardia. So if there is bradycardia, then my drug of choice is ephedrine. Remember this. So spinal anesthesia induced hypotension, what I'm going to use, it depends upon the heart rate of the female, right? Female I'm saying is because it is mostly seen during labor, in a female of labor. So if there is bradycardia, I'll go for ephedrine. If the heart rate is normal in the female, I'll go for phenylephrine. Now usually phenylephrine is more preferred because it has lesser fetal effects as compared to ephedrine. Let us have a look at the next question. It's a clinical question. A patient complained of vertigo and was started on Vertine. Vertine or beta histine is known as Vertine. It's a very popular drug. Vertigo, Vertin. See, this is how companies they market the drug. The more the drug's branded name is close to the disease, the more appeal it has got, right? By a chemist. Oh, chemist has prescribed this drug. Now, this is something that has happened with me. So I have made this question on my own personal experience, right? I'll tell you the story. It's a very small story. However, he did not respond and went to a doctor who asked him to explain vertigo, to which he said he develops dizziness for a while getting up from sitting position. Which of the following drugs should be the patient be started on? So as I told you guys, I'll tell you a small story that I tell in my classes as well. So it happens so that there is a chemist nearby where I live, and I go to him to buy drugs. Once I went there to buy some drugs for family, and that is when a patient comes and he said to the chemist, he's a known to chemist because I've been buying drugs for many years. He knows me very well. The patient comes and said, brother, you prescribed me this Vertine for vertigo. So in Hindi also, उन्होंने बोला भैया ये चक्कर के मेरे को चक्कर आ रहे थे आपने दवाई दी थी ना ये काम नहीं कर रहा. He said that you gave me this drug for vertigo, it's not working. And that chemist knows that I'm a doctor, though I don't treat patients, right? He knows that I'm a doctor, and my world is world of drugs. He knows that. So he asked me, brother, can you see this patient? What's wrong? Why is he not responding to Vertine? So I just asked him. I asked him. I asked him, what are your symptoms, right? And he said, I get vertigo. In Hindi, तो मैंने उससे क्या पूछा कि भैया क्या दिक्कत है? उसने बोला सर मेरे को चक्कर आते हैं. अब देखो, you cannot take a patient by his word. So I asked him, चक्कर का मतलब क्या है? चक्कर, what do you mean by vertigo? Explain me vertigo. चक्कर समझाओ मेरे को क्या है? Right? Then he could not answer. Then I asked him, अच्छा ये बताइए कि जो चक्कर जब आते हैं आपको हमेशा आता है कि लेटे लेटे बदलने से आता है, दैट इज बीपीपीपी, राइट? या फिर बैठे हैं और खड़े होने के बाद चक्कर आता है? सो आई आस्क्ड हिम, टेल मी, व्हेन डू यू गेट vertigo? Is it when you're lying down then also you get vertigo, or you stand up from sitting position then you get vertigo? Now he told me that normally whenever the moment I stand up I feel dizzy and I find something to hold on to, then I stabilize after some time and then I can do my work. So guys, it is basically, can you tell me what is the diagnosis here? What is the diagnosis? The diagnosis is postural hypotension. So the diagnosis is postural hypotension. And again, so this MCQ is asking you what is the drug of choice for postural hypotension? What is the drug of choice for postural hypotension? So yes, the drug of choice for postural hypotension, all of you know, is midodrine. Now this MCQ has already been asked. What is the drug of choice for postural hypotension? I have just made a clinical case which I have myself experienced, right? So though I don't like to treat patients, not because I hate patients, I don't like to treat patients for a simple reason. Just prescribing a drug to a patient is not enough for my duty as a doctor. He needs to follow up as well, right? I don't have a clinic. Where is he going to follow up with me, right? And you can't find me at one place. Today I'm in Delhi, tomorrow I'm in Chennai, next week I'm in Mumbai, next week I'm in Kolkata or Hyderabad somewhere. So you can't follow up with me. That is the reason why I discourage people to, take drugs from me, because telling the drug is only, half of the job done. Half of the job is you need to follow him up regularly and see how he's doing, right? So anyways, because he was a poor patient and I said, okay, anyways. So I'll tell you the story. It's not yet over. So I told the chemist, brother, here's a case of something else. This is not a case of vertigo. So give him midodrine. Now midodrine is pretty costly, right? It's not cheap. So as the poor patient saw the, price on that, he said, sir, I cannot buy this drug. It's very costly. Then I told the chemist, bro, bring out this drug, which is dirt cheap drug. So I told him to bring out an alternative to midodrine. Can you tell me which drug it could have been? It's very dirt cheap, right? So midodrine is costly. It is a drug of choice. The alternative, we can also use fludrocortisone. Fludrocortisone can also be used. It is cheaper, much cheaper, but it is not as effective as midodrine. You have to understand, right? So answer is midodrine, guys. Postural hypotension is the diagnosis. Now moving on, next question. Which of the following drug can block hypokalemia caused by salbutamol? Which of the following drug? Again, it's a difficult MCQ. You cannot answer this MCQ until and unless you have understood the concept as to why a drug like salbutamol causes hypokalemia. Look at the option: isoprenoline, digoxin, mirabegron, potassium chloride, right? Look at the options, try to find the answer. See, here, even if you don't know anything, you can still find the answer. You just have to rule out. So I've told you many times, you will not know the answer directly. Even then, you can find the answer. The only thing is you have to be a little bit smart. So what is salbutamol? It is a beta-2 agonist, which means the hypokalemia would be related to beta-2 receptors, right? All right. What is isoprenoline? It is a beta-1 and beta-2 agonist. So can a beta-2 agonist block hypokalemia caused by beta-2 agonist? No, it would further cause more hypokalemia. So isoprenoline cannot be the answer. Digoxin, it's a sodium potassium ATPase blocker. Now, can it block hypokalemia? Okay, I cannot find the link. Leave it for the moment. What is mirabegron? It is a beta-3 agonist. It is a beta-3 agonist. So can a beta-3 agonist block hypokalemia caused by beta-2 agonist? No, it cannot. So I've ruled out beta-3 agonist. Right. Potassium chloride. Now, potassium chloride, can it block hypokalemia caused by salbutamol? Now, if you look at the word block hypokalemia caused by salbutamol, now if there is hypokalemia, that potassium can be replenished by potassium chloride, but there is no way potassium chloride can block the effect of salbutamol. So even this is not the answer. So if I can rule out, I can get to my answer of choice as digoxin. Now I'll explain to you guys why. Why? Now see, salbutamol, all of you know, is a beta-2 agonist, and because of which it increases cyclic AMP in your skeletal muscles. Now, whenever I increase cyclic AMP in skeletal muscles, what this cyclic AMP does in skeletal muscles, it activates a pump called as sodium potassium ATPase. And what is the role of sodium potassium ATPase? To pump sodium out of the skeletal muscle and potassium into the skeletal muscle. And that is the reason why potassium levels in your plasma declines. So hypokalemia that can be seen is because of this reason. Plus salbutamol also increases release of insulin. Main mechanism is this one. So now you have got the answer. Why digoxin is the answer? Because digoxin is a blocker of which pump? Sodium potassium ATPase pump. This is the explanation. And by this MCQ, I just explained how many a times, if you don't know the answer directly, please don't lose hope immediately. Try to reason with the options and the drug or the MCQ which has been asked. Many a times, I'm not saying always, many a times you'll be able to find the right answer, right? Now moving on to the next question, guys. All of the following are uses of prazosin except. See, prazosin is a very commonly asked drug. Now I made a new MCQ, and again, in this MCQ, look at the options: scorpion bite, hypertension, nightmares associated with PTSD, insomnia. All of the following are uses of prazosin except. Now here, look at the option, and again, I'll teach you something here. While solving MCQs, you'll be able to rule out two options. So I can rule out that all of the following are uses. So is scorpion bite a use? Yes, it is a use. Is hypertension a use? Yes. So these two things, any NEETPG aspirant or FMGE aspirant can rule out these two options even during their sleep. I'm pretty confident about that. Now, I'll be left with two options. There will be a lot of MCQs where you would be left with two options, and you have to compare. You have to compare and try to find the right answer. Now, even if you don't know, you have to still go and attempt that question because you have 50% chances of getting the answer right. So now that we have ruled out two options, let me know what do you think is the answer in the comment box. Come on. Commit to an answer. Commit to an answer, guys. Is it C or is it D? Guys, if you don't know, it's okay. If you've gone wrong, it is okay. It's my right to go wrong because then only I'll begin to go right most of the times. And your answer is insomnia. So insomnia is the answer. Insomnia is never seen. You can see, I never use it for insomnia. I use in scorpion bite where there is hypertension and pulmonary edema. Drug of choice is prazosin. Remember, pulmonary edema with scorpion bite, furosemide is not the drug of choice. Still, your answer is prazosin because here the pulmonary edema, the cause is high blood pressure. Hypertension, I can use it. It's a second line drug. Now, nightmares with PTSD. This is one of the uses of prazosin. Why do I use it? See, patients who develop nightmares in PTSD, it is related to an overactive sympathetic drive that is present in the patients of PTSD, and it is thought that nightmares are because of alpha 1 receptor stimulations, right, in the brain. So that is the reason why this is one of the uses. So what I've taught you today is something extra. So I've told you what you need to do in these sessions. Whenever you get something extra, take those points, add into your notes at a particular point, right? You can add them to a particular section in your notes. Which of the following beta blocker can lower blood pressure in a hyporeninemic patient? Now, see, you know the answer. The only thing is you need to learn how to process this information. Again, it's a new MCQ. Such MCQ has never been asked. It can be asked. Concept. Let us learn about concept. Whenever I block a beta blocker, it can decrease blood pressure. But when is what I need to learn. When a beta blocker can decrease blood pressure? When renin is high or when renin is low or normal? So beta blockers, the way they decrease blood pressure is by blocking beta 1 receptors in the JG cells, and that decreases renin, and that to decrease blood pressure. So remember, the basic concept is beta blockers cannot lower blood pressure if renin is not high. That is the reason why beta blockers or RAS inhibitors are used in hypertension only if the cause of hypertension is renin. So only in hyperreninemic hypertension I can use beta blockers, right? So if there is a hyporeninemic patient, can a beta blocker decrease blood pressure? No, they cannot decrease, but there is a condition applied. Do I have beta blockers which can decrease blood pressure independent of renin? Yes, do I have? I have some beta blockers which are vasodilators, which are third generation beta blockers. So this MCQ is basically asking you indirectly which of the following is a third generation beta blocker, and to that, what is my answer? Labetalol. You got my point, guys? So labetalol, all of you know, is an alpha blocker and it can decrease blood pressure even if the renin is normal or low. So you can see, as I said, in these sessions, I'll ask you MCQs to tickle your brain so that you can learn something new, right? What is the fun of asking the same PYQs time and again, right? You might have developed already nausea, vomiting, solving those PYQs time and again, right? All right, guys. So now we have come to the last question for today's session, guys. A patient of beta blocker overdose was started on intravenous glucagon. Which of the following is a possible mechanism of glucagon? Now see, beta blocker overdose. So look at the option. Option A, stimulation of beta 1 receptors. Option B, upregulation of beta 1 receptors. Option C, stimulation of adenylate cyclase. Option D, upregulation of adenylate cyclase. Take your time, pause the video. This is the last question for today. And you can let me know the answer in the comment box. Then I'll go to the explanation and discuss this. I hope you guys have commented. Now see, many of you might think that the answer is A or B. It is not. It is not. A and B is not the answer. Beta blocker. Now see, beta blocker, what they do? They block beta 1 receptors, right? And if I block beta 1 receptor, it's a GS subtype. That would decrease activation of adenylate cyclase. And that would decrease cyclic AMP. It would decrease cyclic AMP, right? Now, what happens when I give glucagon? Glucagon, whenever I use as an antidote, what it does, it stimulates adenylate cyclase independent of beta 1 receptors. So inside the cell, it directly stimulates adenylate cyclase and can increase cyclic AMP and reverse the effect of beta blockers on the myocardial cell. So answer here, it is not upregulation of adenylate cyclase. See, whenever I talk about upregulation or downregulation, it is related to receptors. What is the meaning of upregulation? Whenever you block a receptor too much, there is upregulation of receptor, means number of receptors increases. Whenever you stimulate a receptor too much, there is downregulation, which means what? Number of receptors will decrease. So here, D is not the answer. C is the answer. Stimulation of adenylate cyclase. So guys, this is what we had to discuss today. In this section, I've discussed 15 brand new MCQs that I've specifically made, right? It takes a lot of time and effort for me to make these questions so that you guys can benefit it. If you are benefiting from these questions that I'm making and discussing, please let me know in the comment box, because your comments and your kind words, they kind of work like a serotonin and endorphin for me to work even harder to make your lives easier, right? That is my ultimate motto is I live for you guys, and whatever I do, because it's the only job I do, and I take time from my schedule to make these MCQs, do these sessions. And today, by this session, by today, as you would have seen, gradually, day by day, right, we have completed already two topics, right? Two topics. And now just try to remember or recall whatever you have studied. You'll remember a lot of stuffs. This is the magic which weekly pharmacology does with your brain. By repetition, we try to learn them for a longer period of time. And you will see towards the end, fag end of your prep, when you're towards revision, you'll see that you would be invincible with this. So guys, again, thanks a lot for participating, enthusiastically in this session as well. And as I do, I'll be posting the next week's schedule for cardiovascular system on Instagram as well as in YouTube as well. If you don't follow me on Instagram, this is my ID at the rate of Doc Pharmaniac. This is my Insta ID. There I'll post the schedule, right? Today itself I'll post it so that you can begin your preparation from tomorrow, right? So a lot of people, they have asked me to do this session at 8 o'clock. Some have asked to do at 10 o'clock. So what I've done, I have added 10 with 8. It is 18 divided by 2 is equal to 9. So we'll keep it still at 9 o'clock, because I know, see, I cannot cater to individual needs, even though I want to. I cannot do that because you are a huge bunch of students, right? So if you're not able to attend these premieres, you can later come and watch. There is no harm in that. But I would advise you, if you can take out time, you try to come in the premiere, because there would be a lot of students commenting, and that has kind of a collateral motivation. So I would also comment, right? And it kinds of give us a community feeling where all of us are together in the same boat and trying to travel in the same direction, right? So it kinds of give you a motivation, as I said. And I'll also be in the chat box, since it is a premiere session. I'll be in the chat box, and I would be pushing you guys to do more in these sessions. And I'll try to make at least one session live. I'll try to make the next session live. Mostly, I think next Sunday I would be free, so I'll do the next session live if possibly. And guys, that's all. Thanks a lot very much, and all of you take care, guys. I'll see you on the next session. Lots of love and blessings to all of you.